next 40 minutes. We'll all keep awake and learn something. We will have 3 cases. We'll do whatever we can in the next 40 minutes. So this is a 36-year-old lady with no comorbidities. She underwent a laparoscopic cholecystectomy for abdominal pain. And let's not get into what imaging was done and all that, but during the surgery, she was found to have liver metastasis. So she had a CT scan and an MRI immediately post-surgery for whatever reason, non-enhancing liver lesions. Yes, we will start with you, madam. Right. So, yeah. So Viraj guessed this. I don't know, Viraj. We might have discussed this lady earlier.
I think so. No, when I saw that.
Oh, did you? So you must be having the answers ready then.
No, because you had asked me last time.
Oh, did I? Correct. I was going to tell Viraj that these are some cases that we had discussed in our, T2021 last year, right? Very nice. Anyway, everything gets a new perspective when you have new panelists. Right. So a biopsy showed a poorly differentiated carcinoma, query neuroendocrine tumor. Yes. So that must be familiar. So let me read through that and then I'll ask you the question, madam. So this reads like this. The description is that the tumor is arranged in nests, trabeculae, and lobules. I don't have the picture. I'm so sorry, madam. With a few cords in loose fibrous stroma. So that's the description. The mitotic figures are 10 to 12 power per 10 high power field. Synaptophysin, chromogranin, both are positive. And the proliferative index, or MIB1, is 30 to 40%. So the description is disconnect with the mitotic figures, which is disconnect with the Ki67. So that's why you are starting the...
Yeah, fine.
So is that description typical of a well-differentiated neuroendocrine tumor, or is it neuroendocrine carcinoma? Let's start from there. I'm sorry I don't have the pictures, madam. That would have been much better.
See, they are saying here that hyperchromatic. Yeah, they are saying that the nuclei are hyperchromatic. So in neuroendocrine tumor, well differentiated, the nuclei are supposed to be monotonous, indistinct nucleolus. So hyperchromatic nuclei doesn't go with a description of well differentiated neuroendocrine tumor. And intranuclear inclusion is kind of a non-specific. You can get intranuclear inclusion anywhere.
Right.
That's okay. The discrepancy in mitotic figure and Ki67 is known, but this is a bit of a too much, that 10 to 12 and 30 to 40. One can have more Ki67, that is the usual practice. And synaptochromocyto, only thing is that in the beginning they have said that a poorly differentiated carcinoma / neuroendocrine tumor. Sometimes one does wonder in the liver that whether this is a well-differentiated hepatocellular carcinoma versus neuroendocrine tumor. But in such circumstances, I usually use the term epithelioid tumor. I don't categorize it further as whether it's a carcinoma or a neuroendocrine tumor, because sometimes it is difficult. So I think these are the few points.
So you agree with the diagnosis of a metastatic neuroendocrine carcinoma here?
No, I didn't read that. No. See, usually,
so what would be your diagnosis if this was the description?
Right. Usually neuroendocrine carcinomas are supposed to be having a Ki67 of more than 55%.
So based on...
based on this, I would say that that hyperchromatic nuclei are a bit, somebody has gone overboard. So this would be Ki67 is how much?
30 to 40%.
30, so G3, well-differentiated neuroendocrine tumor.
So you would call this a well-differentiated G3?
Based on this description, because synaptochromo can be positive in anything.
All right.
30 to 40 G3, it is allowed. And mitotic figures also, they are saying 10 to 12.
So would you put all this together and then give us a diagnosis, or would you say, based on the morphology, you will say whether it's a carcinoma or well-differentiated and then add the rest of it to it? How do you go about it?
It is usually morphology.
Yes,
it is
so based on the morphology...
Morphology, they have said...
hyperchromatic, you said that's typically not what you see in a well-differentiated one. It's usually a carcinoma.
But I think that pathology
needs training. Okay, so as confused as the clinician himself.
Needs training in how to write
pathology, lovely. That's the first time I'm hearing an answer like this.
No, because that is not the way one describes the report.
Because this is not an uncommon problem for us at all. So Shekhar sir, you are the senior most medical oncologist, so you must have seen plenty of reports like this in your 30 years.
Yes.
So how do you handle this?
We do see very often that they come.
So you're starting with a diplomatic answer. What
So
do you do next?
I would say it goes more like a neuroendocrine carcinoma. Why
You're
I'm
saying
telling
it.
yes,
Okay,
because
okay.
poorly differentiated carcinoma in morphology,
Right.
Ka67 telling 30-40% go like that. If it is a well differentiated tumor on a morphology, with Ka67 30% also, I'll say that G3 of a well differentiated tumor. That is how we differentiate.
So a well differentiated G3 slash carcinoma.
Neuroendocrine carcinoma.
So it's that
if,
borderline is what
yes,
you're
yes.
saying. Very good. Amit, yeah, go ahead.
So you commented on that the criteria for calling carcinoma is more than 55%.
Morphology plus more than 55%.
But,
Ki67, what happens is sometimes one has to know that where the sample has come from. If the
Madam, assuming everything is fine. So,
Good pathologist. Good. No, I'm saying this is the good pathologist, good pathology.
excellent.
So
pathologist.
based on 30-40%, you will refrain from calling it carcinoma?
usually carcinomas have a much
Usually, but I think Amit
How
has
do you
got an
define?
important point there because,
see the morphology first. If the
Right.
morphology is classic of a neuroendocrine carcinoma, it has to be called a neuroendocrine carcinoma. What do I mean by morphology is highly atypical nuclei, they should be pleomorphic. In small cell, you would not see discernible nucleoli, but they are small cell means highly pleomorphic smudge nuclei. If it's a large cell neuroendocrine, one can say prominent nucleoli. But both the carcinomas, one says carcinomas, the morphology is typically of a high-grade carcinoma. So morphology plays the higher role than
excellent.
others.
So that's the point.
Not the
Amit.
KS67.
Not the KS67,
So-
and that's why this table, I have put up this table. You can,
And
look at it.
55 was a thought process from the perspective of giving chemotherapy or not. giving
Chemotherapy
chemotherapy.
versus not, whether Dr. Kallur comes in very early or not, all these things matter, whether your response to platinum is good or not, whether your response to Captem is bad or not, all this comes. So essentially for audience who are starting to get confused already, the differentiation matters, that's the first thing. So morphology is what tells you whether it's a well differentiated neuroendocrine tumor or is it a carcinoma or not. A carcinoma can be either a small cell or a large cell. Dr. Kallu showed you a large cell carcinoma. So it's purely based on differentiation, morphology, nothing high tech. And you can have a Ki67 of anything more than 20% even in a carcinoma. So the Ki67 does not determine whether somebody's got a well differentiated or a carcinoma. So that's the important point, and that's what I want you to learn from this particular slide.
But usually in neuroendocrine carcinomas, when we say carcinomas, especially in biopsies like lung, where this distinction particularly matters, Ki67 is one of the things. Like we have to see Ki67 more than 50% because
Correct.
sometimes
So it's usual.
usually.
I think that word is very important. Usually
the
but
Ki67
not
of
always.
carcinomas is supposed
And
to be
I
60
think
to
the
80%.
behavior of Ki6710 is very different in a pancreas versus a small bowel versus a lung. So I think we understand those intricacies, but in general, we are making some general points here. Okay, let's come to this. So Viraj, what do you do when there is a discrepancy? Whom do you look up to? Pathologist says, this is all that I can say. This is the final report, and that's about it.
This is the disease where imaging trumps even more than
Excellent.
histopathology.
So we look
So
up to
I
Dr.
do
Kallur next.
Yeah, FDG. If FDG is weak, then we always do DOTA at our institute.
Excellent. So this is, okay. So in a patient like this, you would do both?
First FDG. Let's
Okay.
say FDG is showing.
Because the Ki is 30-40?
Right.
Would you do both? All the more reason because he did show you some cases
Yes.
where...
So in that.
So let me rephrase the question. When would you do both?
10 to 20 is where it is a tumor, not carcinoma. Carcinoma, I don't do first always. I do some point in time.
Right.
That's a take home. But if it is a tumor, 1, 2, 3, G1, 2, 3, it's always both.
G1?
Not G1, 2, 3.
Excellent. So G2, would you say some Ki67?
More than
cutoff?
10. More than 10.
Okay, more than 10. Amit, would you agree with that number, or you would say all G2s should have both? G2, G3 will anyway do if it's less than 55%.
So when I'm convinced about a low-grade tumor, a low or an intermediate-grade tumor, I would start with a Dodonok PET CT.
Okay.
And if the PET CT guy tells me there are areas which are morphologically abnormal, and they're not taking up Dodonok scan, and he raises the flag that you should be doing an FDG glucose as well, then we obviously order. So we don't order blanket
Okay.
both come. But on the other hand, if somebody has a 70-80% KS67 morphological
don't ask
abnormal,
for a Doton.
we actually start with the FDG.
FDG.
And if there is a comment by a nuclear medicine guy that it's not clicking very well, then
Dr. Kalur, your thoughts before I move on.
I agree with whatever he has
Excellent.
taught, yes.
Excellent. So this is the FDG PET. In fact, I've underlined all the SUVs there so that we can then make a decision easily as to whether you want a Dotonok or not. So that's the pancreatic lesion showing an 8.2 SUV, not bad. I mean, would say slightly on the higher side, consistent with higher grade tumor. SUV max 11 in the liver, multiple lesions. But when it comes to some lung nodules, it's 2.6, and when it comes to a rib lesion, it is 4.8. So kind of a little daisy. Sir, would you ask for a Dotonok PET in this patient because all
Yes,
values are not on the same
Yes,
side?
you can consider Dotonok
You
also.
will do a
Yes,
Dotonok.
yes.
So in general, yeah, Sairam, please go ahead. You want to radiate the rib? No. Okay. Go ahead. Go ahead. he's saying this. Okay. Sairam, sorry. Absolutely. Absolutely. Okay, so I think everybody's got their own policies because in a center in Hyderabad, Viraj, I'm talking about both prostates. When we send it later during the course of the disease, they always do an FDG and a PSMA, and now sometimes Dotonok also for triple therapy. Okay, your point is well taken. So if somebody's got a grade 2, I mean, just to make things simpler for the audience, if somebody's got anything grade 2 and beyond, it'll be okay to do. So anywhere between, let's say 5, I would put it rather than 10, 5 to 55, easy to remember. It may be worthwhile doing both scans upfront rather than waiting to do one after the other, because then you can sequence, what all therapies your patient is going to qualify for. Harit sir. Absolutely. With this, so you've been disagreeing with everything else that I was saying so far.
So,
Amit.
so the problem with the dual PET-CT is
Yeah.
subsequent investigation would also require a dual PET-CT.
Meaning, Amit?
If you have done 3 months, 4 months of treatment, so there are few cases in which now you will be asking for a dual PET-CT again. So you have to be categorically clear with the patient that, you can do a 2 PET-CTs right now, and then 6 months later down the lane.
So, sir, the point is you have a practical issue there, but the point I'm trying to make is that if your other scan is not showing up anything at all, and then, so that you know your options, so that's the point, so that you know when Dr. Kalur will come in. So that's the reason. So we did do a Dotonok PET April 19. It shows that all the liver lesions are somatostatin receptor negative. That rib lesion is Krenning score 1, and that pancreatic lesion is also not actually taking up. So as Viraj said, when the pathologist is unable to decide what the grade is, and that's problematic, we actually look up to the nuclear medicine physician, because that is much more objective in terms of what it is going to show. So then we got it reviewed by another pathologist, which only added to more confusion. And as always, for clinical correlation, isn't it? I don't know what to correlate with in a situation like this. Madam, quick comment before we move on, because we are already done 10 minutes. So that's another pathologist, so that's only adding to the confusion. So that's why I've put everything together with clinical correlation. I've said pancreatic. No, okay.
G2, G3, liver and bone.
That's my final diagnosis. Pathology, nuclear medicine, histology, everything put together. Because you asked me to clinically correlate.
No, see, in
No,
neuro...
okay. No, let's move on, madam. We are getting stuck there. So the point, ultimately with the Ki67s, everything put together, this is my diagnosis, a pancreatic neuroendocrine tumor. I said well differentiated, but a grade 2/3, because the Ki67, as you said, is on this side. Liver and bone metastasis, pancreatic primary, obviously. So that's where we are. Let's say that the Ki67 is 40% for the rest of the discussion's sake. Okay? No, you don't want it? 15%? All right. So let's go on. So Amit, let me start with you again. So does the Ki67 or the differentiation or both decide the choice of chemotherapy in this patient?
I don't have instructions over this in the...
Okay. Sir, please go ahead.
My question before this,
Ah.
Kallu, Ki67 is 15. That's what we are.
So there is a lot of discrepancy, sir. In the earlier one, it was 30 to 40, and then another pathologist said 15.
Well differentiated. So under those circumstances, are we not going to
Yes, it can reveal. We have seen. It can reveal. Yeah. Yes.
So I have to be fair to the pathologists because both the pathologists who looked at it were ladies. Right? So I have to stay with both of them. So I can't be unfair to one lady. So I said both. Yeah, Bishwa. Oh. So net pet score, the FDG is taking up. Madam, this you have to answer.
+1.
Should we just take the pathologist away and do everything with the nuclear medicine physician?
For neuroendocrine, take the pathologist away. No, not at all.
Not at all.
Not at all.
They may take the
Because,
clinician away, but
no,
not
no,
the
no.
pathologist.
No, what I was going to say is, even in, for that matter, even in GI neuroendocrine tumors or pancreatic, I was just going to go back on the previous slide. The Ki-67 for high-grade carcinomas is more than 75%, according
so
to
it's kind of-
WHO to latest grade.
All points
So
well
what
taken.
we are dealing with, I think, is either a G2 or G3, well-differentiated
That's why I said
neuroendocrine
G2
tumor.
or G3
So,
because we are not very
it
sure.
is important to have pathology because whether it is a high-grade carcinoma or a well-differentiated tumor. That is how you are going to...
So the point Biswa is trying to make is that we have not been able to do that very clearly with pathology.
Correct.
Point well taken, Biswa. That's why I think Viraj said we will then look up to Dr. Kallur to give us the final verdict. So that's what he meant. And it's fine. I think we have to put everything together. That's reality. Amol? Ah, correct. Correct. So this is typical physician, isn't it? Talking about it all the time. No action, only talk. Correct. Ultimately, you'll say incurable, nothing will happen, all this story. We'll come to that later. We'll come to that later. Okay, Viraj, you've got the mic in hand. Ki-67 differentiation, what helps you decide on the chemo? I've just put up the numbers for platinum-based chemotherapy on that side. I'm sorry, the print is very small. ORR stands for overall response rates to etoposide platinum. You've got a grade 3 well-differentiated neuroendocrine, and you've got a neuroendocrine carcinoma, the point that Amit was trying to make. You can have a Ki between 21 and 55 there. It's not a compulsion that you should not. No, madam, I think that's the guideline. And then you can have a carcinoma with a Ki-67 of more than 55%. So, Viraj, how do you decide on the chemo?
So yeah, Nordic trial told us that Ki-67 more than 55, platinum-based doublet chemotherapy gives a better response rate.
Right.
While a lower Ki-67, one could get away by doing a oral pill like Captem. That's what we
Captem.
do in practice.
Excellent. So you can see the difference in prognosis just based on whether it is well differentiated or it's a carcinoma. Responses might be very different, but look at the overall survivals, 33, 11 months and 11 months. So the outcome is very poor the moment it ends up being a carcinoma, even if the Ki-67 is less than 55%. Amit rightly said we don't have streptozotocin in this country. It's never been there. Shekhar sir, MGMT promoter methylation or not, assuming that we will do Captem for this patient, would you like to do this marker? If yes, what technique do you routinely use? And the reason I am asking this question is E2211 read out at ASCO this year.
So, yeah, basically, it is a very important investigation because 80 to 90% of the people who are unmethylated respond to MGMT inhibitors. That
Right,
is why,
85%,
yeah,
you are correct.
85%. So, it is very important if you do it. Even otherwise also we see good amount of responses.
It's
even
like
when you are-
PDL1.
Yes. It
Amol,
is.
it's like PDL1. If you're positive, you respond well. If you're negative, you still respond. So we'll use it for everybody.
So, yeah, and
That's the
so,
confusion.
that will be the best combination. Captum will be the best combination in this well-differentiated.
Very well made point. So they also very interestingly did an IHC test. I don't know what they tried to do because it's kind of adding to the confusion. For me, the standard technique that we use is a PCR to look at promoter methylation. If there is methylation, then these patients do very well on Captem, and that's probably a marker. But as Shekhar sir rightly said, it's not a compulsion. If you're negative also, you tend to derive some benefit. In fact, there was at one point in time some data in GBM that if you're negative, you don't have any benefit at all. It may actually be a little detrimental to do temozolomide and radiation therapy, but we've kind of compromised saying the trial was not powered to look at this particular question. So we will, in the future, if possible, do another trial to look at this question, which will never be done because Amol knows the answer to that question. Excellent. So we will move on. So if possible, you can do it, but it's not a compulsion to go and do it. So this is a nice algorithm I thought for for deciding on how to approach the chemotherapy issue in a patient with a grade 3 tumor. So according to this algorithm, at least, if you have a well-differentiated tumor and it's grade 3, CAPE-TEM seems to be the way to go. This is a personal opinion. I don't know whether it's been submitted, accepted, and published. I didn't go and search for it. But if you have a neuroendocrine carcinoma, the moment they say it's a carcinoma, a platinum-based chemotherapy seems to be the way to go. But I also agree with Viraj that CAPE-TEM is not a wrong choice, because CAPE-TEM comes second in a carcinoma with a lower Ki-67. If it's more than 50, 55, I think the decision is unanimous that they should go on a platinum, carboplatin containing chemotherapy, and then everything comes afterwards. So this, I think, nicely sums up the way you approach the chemotherapy issue. Remember that in a pancreatic tumor, you might have good responses to CAPE-TEM even if the Ki-67 is quite low. In a colorectal tumor, you may not have Ki-67, you may have a high Ki-67, but the response to CAPE-TEM may not be good. So remember that though we are putting this Ki-67 into a compartment, it's a continuum, and it might vary in terms of how it will impact the biology and responses to your treatment. So keep that in mind when you're approaching your next patient. So this is the ESMO guideline. Again, Viraj pointed out the cutoff 10%. This is for pancreatic neuroendocrine tumor. So if it's less than 10%, Dr. Kallur takes it. If it's more than 10%, Amit, Viraj, and Dr. Shekhar will take it. So that's roughly the cutoff. But again, remember that these cutoffs are for making things clearer for people in the clinic to approach it. But remember that it's going to be a continuum. Harit sir, any role for surgery?
Yeah, so one must remember surgery is the only
I
thing
did
which
not forget.
has
That's why I
curative
asked you.
role. And I
That's why I
think we
asked
are hovering around everything other than the main thing.
That is why I came to you, because you
Yes.
should have the final say.
Yeah,
Sir, surgery for this patient?
so not for this patient.
Excellent. So surgery not
Accepted
for
that.
the. Okay, so before.
But had it been limited disease, grade 1, low Ki-67, surgery is not for lung and bone and all that.
So Dr. Kallur, you were repeatedly mentioning about surgery followed by PRRT and vice versa.
yes.
The reason why I'm asking this question, if you look at the subset analysis in the NETR, anybody who had a liver tumor that was more than 3 centimeters did not do very well.
Yes.
So do you think there is a role for Dr. Harit to come and resect a part of it and then send it to you? Do you think that's the way we will
because there
manage?
are other trials also. Don't look at only one.
Because that's the
Because
largest
yes,
published one.
surgery is the treatment of choice. I agree with him. If we are able to cause some amount of a tumor regression, I have given one example also. They will do well. Even the primary bulky tumor is there, that may be causing some problem to them, debulk as much as possible. But in this case, I would like to beg with G1, G2 also. The trials are coming, along with your chemotherapy, whatever you are giving, do PRRT also concurrently.
Sir, but if the DOTA PET did not show any uptake
Then,
at all.
then no. Then
Correct. So this patient, the DOTA PET was showing no
no.
uptake.
Negative. Then don't. If it is positive, then.
Point well
okay.
taken. Your point is very well
The
taken.
picture that you showed is a comprehensive picture because there is one liver met, one pancreatic.
It's not, the others are not showing up very clearly, Amit.
Because if this is the picture, then the surgery will.
Absolutely. So, but even then it's a little bit, because there are a few lung nodules, there's one rib lesion, there are a few. This was before the COVID era.
So, sir, one point I wanted to make.
Yes,
For
please,
G1, G2 tumors,
Yeah.
you mentioned about debulking, concept of debulking. It's the same phenomenon we saw in PROMIT study, that if you debulk the liver and leave something behind also, they do better on standostatin versus not. And same thing you saw with NETR1. So I think so there is a role of debulking if you have G1, G2 tumor.
Point well taken. Point well
Because
taken.
surgeons usually take a pride, if I can't do R0, I won't do it. But it's an
No,
important
I think
point.
Dr. Kallur spoke a couple of times
that
about 90%
even
and
debulking,
70%.
yes, debulking should be done,
Especially if they're symptomatic.
especially symptomatic.
Correct. Symptomatic because of the anatomy, or symptomatic because of the biochemistry? Both. Both. Mostly biochemistry, but it could be because of the anatomy also. Right. So we'll quickly run through 15 minutes. I've got 2 cases. So this is an interesting, again, sir, you. Oh, please. Thanks so much. Thanks so much. Thanks so much for being there. Right.
So you are the nuclear medicine guy.
So now that Dr. Kallur has gone away, we can say anything about nuclear medicine, right? And get away with it. Right. So this is a 62-year-old male, multiple comorbidities, chronic liver disease, hemicolectomy in 2009. That was about 8 years ago for a carcinoma cecum T3B N0M0. Laparoscopic cholecystectomy, again 2009, diabetes mellitus, hypertension, Crohn's disease, and then query liver metastasis. So he presented with intestinal obstruction. Peroperatively stricture in the jejunum with an exophytic mass infiltrating the mesentery, retroperitoneum, mass encasing the superior mesenteric artery and vein, enlarged mesenteric lymph nodes. So they could not resect this, no 70%, 90% here. Loop duodenojejunectomy was done. So this guy's brother also had a neuroendocrine tumor. Another brother has a thymic neuroendocrine tumor. The other brother has got a jejunal neuroendocrine tumor. So it's a family of neuroendocrine tumors. In fact, the other guy recently had a pancreatic adenocarcinoma also, right? Looks like. Excellent. You already got the diagnosis and the treatment right, Amit. We'll come to, yes? Yes, so I can then quick, no, he said Lynch or men? It could be either. Okay, excellent. Thymic. Pancreatic adenocarcinoma. It's not a pancreatic neuroendocrine. Okay, we'll get on. So this guy's brother was being treated in Germany. So obviously, Germany is better than India, right? So he got onto the next flight as soon as he could walk and landed up in Germany in the best center in Europe. Okay, the reason why I'm making this point is, you have to listen to the rest of the story that actually happened. Biopsy was grade 2. Chromogranin was positive. Ki67 was 15%. No confusion there. Chromogranin elevated. And multiple lesions that were showing somatostatin avid, right? And interestingly, though it was 15%, at the time of diagnosis, no FDG PET was done. All right, so the diagnosis was a jejunal neuroendocrine tumor, grade 2, stage 4, multiple medical comorbidities, but he was performance status 0 after the bypass procedure was done. So, Viraj, what would you do? Asymptomatic now, but it's got plenty of tumor. Octreotide, PRRT plus octreotide, everolimus plus octreotide, PRRT alone.
So we do octreotide in this case. Only thing is the family history perplexes me, so I would by side investigate that also.
So you would do some germline testing to check if
test.
something is going on. Shekhar sir.
Yeah, the Ki67 generally.
15%.
That only if higher Ki67, the response to this octreotide may not be that great.
Okay,
Generally we
so
see,
but
generally less than 5%, less than 2%, they do good. Otherwise, generally we have to add something else.
What is that something else?
We can go for the, it is a small intestinal tumor, you can go for everolimus like
Everolimus plus
mTOR
octreotide.
inhibitors. Like
mTOR
that.
at the same time. Amit? Mike. Octreotide for sure.
Controversy on that.
Okay.
I normally go with octreotide only if there's a very large volume of disease. Then I venture for an mTOR inhibitor. I'm tempted to do PRRT first line, but I haven't done yet.
You haven't done...
Done yet.
Okay.
Not the first line. Classical PROMET thing.
Okay. Octreotide with PRRT, excellent. So, intuitively what Shekhar sir is saying is right. Octreotide with everolimus is one of the choices. But interestingly, the study that randomized patients to octreotide versus octreotide plus everolimus did not meet its primary endpoint of improvement in the PFS, though the P value was less than 0.05, 0.05, right? So, but that was not within the statistical limits, so it was a negative study. But we sometimes use it. You're right, though there are some side effects associated. So the reason why I asked about octreotide plus PRRT is, Biswa, how do you so is there good evidence to say that you should combine both, or you can just do PRRT? Netter. Of course, Netter is after they progressed on sandostatin, but I'm just asking you a question because this is another confusion that keeps going on again and again. So how do you do both together? So that's the question. Anybody can take it, or Biswa, you can take it. So is there, you do PRRT alone? Amit? If in case you decided to do frontline, or they progressed and you decided to do PRRT, would you keep the sandostatin on, or would you cut it off?
No, I keep the standostatin.
You keep the standostatin.
Like Netter. Netter had...
You just follow Netter. Biswa, you follow Netter. So again, so how do you see... No, 30 mg plus. 30 mg plus. No, 60 is the escalation arm. So the other arm is only 30.
So with the Netter, the arm was 30 milligram, but you can't give it on the same day.
Excellent. So Amit, how do you sequence it? The PRRT and sandostatin, because that's another question that there's always confusion.
So I start with Promid, Octreotide, and then when there's a clear progression, then
So let's say today you've given sandostatin. When is your PRRT?
at the relapse progression.
No, you're doing both now. So you're following Netter, isn't it?
Okay, so at relapse, I'm giving them Octreotide and PRRT.
Yes.
So
So
what-
today is sandostatin injection. When is the PRRT?
24 hours before or after. That's what we are doing in our institute.
No, let's say today you do sandostatin. Would you do PRRT tomorrow?
We are keeping a minimum gap of 24 hours in our institute.
Okay, I think you need to go and look back at it because
Within 24.
Yeah, Sairam. Correct. So that's what. No, you can start the next sandostatin in 24 hours, but from the last sandostatin, ideally it should be 4 weeks. So
So last.
if you're giving sandostatin every month, so you schedule it in that way. That's the
So
point.
I don't know, but Dr. Vikram Lele of Justlo categorically told me that you could do it.
Excellent.
Within
I'm coming to
24
that point
hours.
next. So is there clear evidence to say that you should not use PRRT the way Amit is saying? No, there isn't.
There isn't.
In fact, there's only one study which looked at 23 patients where they have done sandostatin within about 2 weeks of the PRRT, and they not PRRT, they just did a scan before and after the sandostatin. It clearly showed that there was no decrease in the uptake of the receptors if you did sandostatin. So it seems to be fine to do sandostatin anytime, but if you look at the NCCN, let's say, it will say that you wait for 4 to 6 weeks and then do as Sairam is rightly saying, but it's absolutely fine to do it the way Amit is actually saying. So that's the reason why I asked that particular question. Anyway, to cut a long story short, because I want Dr. Harit to come in the next, what happened to this guy is that, he didn't respond to the sandostatin. So after about 6 months, this is what happened. He started rapidly losing weight, and he was in touch with his physician. I am his local RMP, right? So I will do what the physician in Germany says, right? Because fortunately or unfortunately, it's good in a way because you don't take responsibility for what happens. So this is a CT scan that we got in our place. Extensive peritoneal nodules, and there's a significant increase in the mass. Okay, that's what it showed, and he rapidly started deteriorating. Subacute intestinal obstruction, as you see in the 4th line of that PET CT scan with dilated bowel loops. So this is a scan 2018, 2019. 2019 scan, you see that there's already a drop in the somatostatin uptake that you're seeing here. And this is when he went back to Germany. He was quite sick with intestinal obstruction. He left to Germany on a chartered flight. So you can imagine the wherewithal that he has. So just before he went, I actually got a rebiopsy done because the DOTA uptake had significantly gone down. And here you see that from 15%, it's gone up to 50%, and from a well-differentiated tumor, it's become a carcinoma. And this is what the FDG PET, when he landed up in Germany, showed. Okay? But you know the irony of the situation? 2/9/2019 is the day he had the FDG PET, and 2/9/2019 was the day he had his PRRT, best center in Europe. Right? I don't want to mention the name of the professor. He's been to India many times, and we all look up to him. We continue to look up to him. Anybody can make mistakes. That's not the point, but I'm saying that, ultimately, what is written here is what will happen, right? So the beauty is that in the last summary that they wrote, I also missed this. Look at what they have written, that a second primary neuroendocrine carcinoma is a possibility, right? But I think the more important information in this report is what comes next. Cecal carcinoma, first diagnosis February 2009, MSH2 gene mutation. Okay, they saw this also. And they suggested capecitabine and temozolomide for a guy who's got a high-grade tumor with subacute intestinal obstruction. Sometimes luck is on our side, sir. Right? So he came here, and then I started Cape10 as per instructions from the treating doctor. But then after I saw this report, I put him on, it is MSI high. So he started on pembrolizumab 2019, right? And then after that, there's no looking back, sometimes immunotherapy works really well. And this is his latest scan. This is 9/8/2022, right? Hardly any disease now.
I'm sure if you biopsy this, it will be necrosis.
Oh. so be it. So in fact, I'm going to stop his immunotherapy now because it's now 2 years. So, it's what is written on your here for both the patient and for the doctor. Now I become a, savior.
You are the demigod.
Right. So I'm going to stop it because it'll be 2 years now. So we had a chat over stopping and not, as usual, they are not very happy to stop. They want to do it at some frequency. So I said, once in 3 months, something like that we will do. We'll do something, that's fine. So that's the story of this guy. So I think we need to keep our eyes and ears open all the time and, make sure. I didn't want to discuss comprehensive genomic profiling in neuroendocrine tumors. The higher the grade, the more likely you will find out something. So that's the thing. Sir, this is for you. Harit sir, 54-year-old doctor, performance status 1, no comorbidities, a lesion, that's a pancreatic lesion. It's almost encasing everything. Would you go and do a heroic resection because this Ki67 is only 7 or FDG PET uptake is 0?
FDG is 0, Ki is 6-7%.
7%.
And this is the mass, the vessels are encased.
Vessels are encased, both SMB,
Nothing.
SMA.
No need. The vascularity, you have to check, no need for surgery. You can't actually.
Okay, at least immediately there's no surgery. And there's a small nodule in the tail of the pancreas also.
Yeah. So that alone will not serve any purpose because if you're not able to do the main thing, there's no point in removing that.
Excellent. So
If
for
you are
now.
able to remove 90%, you leave around the vessel, whatever is there, and
You're
remove the rest
removing
of
10%, leaving behind 90%. So I think here there's no purpose served. Yeah. The moment
you
you
are
go
done.
through it, you will mess it up.
Okay. So let's say, doctor, you will do MSI. Okay, MSI is negative. Okay. So, okay, I don't want you guys to go back with the impression that it's very common in neuroendocrine tumors. It's very uncommon. It's just that we stumbled upon it and, that guy was lucky. So was I.
You've chosen all the cases in which Dr. Harith and me had no role.
So you decided that you don't want to resect this guy, isn't it? Okay, Viraj, Harit sir is sending it across to you. Cyto-reduce and send it back. Chemo, cyto-reduce or whatever. What would you choose?
PRRT.
20% response rate.
It's more than
19% to be precise.
It's far more than that in clinical practice.
Nectar is 19%. Are, dekho. Add CAPTEM to it and
CAPTEM
increase the
plus PRRT.
response. Okay, so I think
that.
that's that. So the reason why I put up this case was to show you this, exactly the same issue. Because if you look at the E2211, again ASCO, response to CAPTEM is around 40%, and then you add your PRRT on top of that. So it's exactly the sandwich. There's decent data from Tata Hospital, a couple of publications which I came across, where they have done PRRT this month. The next 2 months you do CAPTEM, and then the next month you're doing PRRT. So that's how they have
Amaya
done
is doing that.
and they have shown some response rates 50 to 70%. So if you're really looking at cyto-reducing your tumor and sending this person for surgery, that's what you should be looking at. And the one on the left is a retrospective analysis. It is pancreatic, non-pancreatic, everything, 116 patients. Look at that, even in a Ki67 that is less than 3%, that's only 24 patients, but you're still getting an overall response rate of 20%. And I think most of that should be pancreatic NET because that's where even with a low Ki67, you're expected to respond to CAPTEM. PET is 0. Of course, in a 7, exactly. So that's the point I was trying to make, Biswa. So it is less likely to work, but it's not that it will not work because you're seeing that in a Ki of less than 3%. Obviously, in a Ki of less than, in a Ki of less than 3%, you don't expect FDG anyways. Unless you made a huge miss and you got a pathologist as bad as me. I think Viraj and Amit were very clear that if it's 2%, 3%, they would not do it immediately. Okay, your point is well taken. That's all right. Yes. So, if you add 6% from 6% from octreotide, 19% from PRRT, and 40% from, then you get. I know, I'm just joking. So yes, I think that's not a bad idea. So you would do your, but interestingly, the ESMO guideline actually says rather it discourages the use of sandostatin and PRRT, while NCCN says it's okay. So there was some reduction after the first PRRT. We didn't do CAPTEM, There was some reduction, but I don't think it's serving any purpose, isn't it?
Not really.
SMS become free, sir?
SMS free.
Should I?
I don't know where are you seeing, because what I am seeing that, okay, I can see that small dot there.
Okay, so now ready?
Oh no, just hold on. We have to be very careful. You can't go in just for the,
See, the pancreatic tail nodule has disappeared.
yeah. So tail is not the bothering thing. It is the bigger
It is
mass
the
which
head
is
that
the real
usually
issue.
bothers, the tail only wags, you are saying. Okay, so that's the summary. So it's very important to have the pathologist. We can't say we will go by the nuclear scans. So that's where everything starts. So we can't forget that. So that's how you will broadly classify these tumors, fully well understanding that this is a continuum. The biology can be overlapping. So the lesser the Ki-67, you're looking at PRRT, sandostatin, everolimus, sunitinib, and all these things. As you go to the right side, you're looking less of all of these things and more of chemotherapy. Well, there's always that, borderline between the two where you need to look at all of these options. Don't ever think that you can throw one of these options out of the bucket or out through the window and then forget about it completely. Most importantly, as Dr. Harith started by saying, please don't forget the surgeon, right? Because if there is something that can cure your patient, correct. So that's why I'm saying it as my parting comment, that please don't forget the surgeon, because if somebody who can cure your patient, it is the surgeon. And we will give full credit to them in spite of all the molecules that we have hovering around and roaming around. Thank you so much, Viraj, again, and I enjoyed doing it as always. I hope you learned something from this.